Hi, everyone. Good evening. I just want to say thank you so much for attending. First of all, my name is Kanza Tahir, and I am a second-year medical student here at Rowan. I am the president of the OBGYN Society as well. And I really want to say a huge thanks to everyone for coming in today. We have been planning this event for quite some time, and we're really excited for this event. And we hope that you guys find it, very interesting. We are co-sponsoring with a lot of clubs, and I want to just say thank you to all those clubs for helping us, reach out and spread the word and advertise. And then there's a couple things I want to just cover really quick as like housekeeping before we get started. So first, this event is approved for both the Women's Health AOD and the Cultural Competency AOD. Please make sure you sign in. I'll put the sign in the chat, and I'll remind you guys again at the end. But even if you are considering and you don't know if you want to do it, make sure you sign in because that's our record. And then I also want to say that please have the layout as either stage or focus. So up on the right side, make sure the layout is either at stage or focus because Dr. Mazzarelli will actually be having his slides on his screen. So we want to make sure that his screen is the largest. And then there will be a question session at the end. Please use the chat feature to put in your questions, and we will get to all your questions towards the end. We have about an hour set aside for that, but we'll use how much ever time we need within the hour. And lastly, we are also recording this session, as you guys I think can see, and Student Affairs will have this available for you guys to review later as well. So without any further ado, I have the pleasure of introducing Dr. Holzberg, who many of you guys probably already know him, but he is a professor and the chair of the Department of Obstetrics and Gynecology, and he's the director of physician engagement at Rowan Medicine. He is also the section head of the Urogyn Department of OBGYN, and on top of all that, he's also our advisor for the Rowan OBGYN Society at Rowan. So he helps us with all of our events, and he was a huge part in planning this event as well. So Dr. Holzberg, we can't thank you enough. Please, would you say a few words?
Hey, Kanza, thank you. My favorite title is the faculty advisor for the OBGYN Society. So if that was the only thing I can do, that would be what I would do. So I appreciate the introduction, Kanza. Thank you very much. So I want to welcome, we have a lot of people already joined, and I'm sure more that will join. So I want to welcome all of our students, our faculty, our staff, and friends that have joined this Compassionomics discussion. A special welcome to our Dean, Dean Cavalieri, who I know is joined today as well, and has told me multiple times how much he was looking forward to today's talk. So thank you, Dean, for joining us for this special event. I want to thank, as Kanza said, all the student organizations that were responsible for tonight's event. The OBGYN Society, of course, as our #1 society for helping with this, but the American Medical Women's Association, the American Association of Physicians of Indian Origin, the Student American Academy of Osteopathy, the Student Osteopathic Surgical Association, and of course the Dermatology Interest Group. All of these societies were key to working together to get this event off the ground, and we're very proud of all these societies and everything that they do. So thank you again to all those organizations and groups for co-sponsoring this event. So I'm actually thrilled to have the opportunity to welcome my friend, Dr. Anthony Mazzarelli, to Rowan SOM. Most of us know him much better as Maz, but in his official capacity, he is Dr. Anthony Mazzarelli. Dr. Mazzarelli is the co-president and CEO of Cooper University Healthcare and the Associate Dean of Clinical Affairs of CMSRU, Cooper Medical School of Rowan University. He is an emergency medicine physician and co-author of the title of today's event, Compassionomics, the revolutionary scientific evidence that caring makes a difference. He, as I said, is board certified in emergency medicine and holds a master's degree in bioethics. And he is, one of those things that we don't like to talk about very much, but he is a lawyer and has a Juris Doctorate from the University of Pennsylvania. Some of his accolades, which are only a few, as I know, he was named one of the 50 most powerful people in New Jersey Healthcare by New Jersey Biz, as well as ROI&J, and was awarded the Halo Award for leading a team of healthcare providers from Cooper into Haiti in the days immediately following the 2010 earthquake. He's also received numerous commendations for leadership and speaks regularly on several local and national media outlets. He lectures at CMSRU to their medical students, as well as to many of the residents and fellows in the area of quality, patient safety, and continued process improvement efforts in the healthcare systems. I, years ago, brought him into my Uruguayan fellowship to talk about, basically the business of medicine. And I think that probably sparked him doing a lot of other talks for a lot of the other residents and fellows. On a more personal note, I've known Maz for, oh boy, well over 20 years. He was my medical student. So when I was a resident in OBGYN, Maz was our medical student, and he was quite a good medical student, right? So, and then he made his way up the ladder, right, to where he is today. He's also responsible probably for a lot of the reasons why I'm in the leadership position today. Your mentor doesn't always have to be older than you. He could actually be a little bit younger than you. So Maz is a mentor of mine, and really I give him credit for inspiring me as a leader, giving me the opportunity to be a leader, and learning from him for sure. So I think that's enough about Dr. Mazzarelli, and I appreciate you, Maz, for being here. Thank you very much for doing it. Thank you for always not hesitating for anything that I or we need here at SOM, and we are looking forward to your talk today. So I will let you take it away.
Well, thank you. Thank you very much, Dr. Holzberg. I really appreciate that introduction, and I think you give me too much credit. I still think I've learned more from you over the years than the other way around, but I want to thank you. I want to thank Kanza, all the student groups, Dean Cavalier for having me, and it's exciting to be here today. And I'm excited to talk about this topic, and give it a good chunk of time to do it, which and then hopefully answer your questions for as long as you have any questions. And and I do want to talk about what we're calling Compassionomics, and I'll explain that as we kind of move along. But we kind of, when either me or my co-author start, we always start by talking about the same. The same sort of story, which is on February 27th, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, 2 commuter buses filled with passengers collided head on. It was a horrifying mass casualty event. One of them was sheared, one of the buses sheared in half. That's the actual picture of one of the buses. And tragically, 6 people lost their lives, but miraculously, 56 passengers survived. You can imagine the scene at the hospital when these passengers showed up. It took hours to extricate all of these people from that twisted metal. The reason why I even have this picture is because it comes from a textbook about how to extravagate from these kind of mass casualties. So 5 years later, in what we believe is one of the only studies of its kind, researchers interviewed all of the survivors, all 56 survivors, and they asked them, what was your experience? And then they recorded the answers, and using a rigorous qualitative research methodology, they analyzed every single word and identified common themes in the data. And 2 themes really emerged. The first was pretty expected, but the second wasn't. The first was the physical pain at the moment of impact. That's what people remembered. And that kind of makes sense when you think about it. So they remembered the physical pain, that was expected. But the second that they all remembered was the lack of compassion from caregivers that took care of them. That was their lasting memory 5 years later. To make that even more interesting to you, if your research brain goes on, realize they were spread across 3 different hospitals. So you can't say it was one hospital in particular. And this is indicative of what we mean when we say there's a compassion crisis. It's not just an emergency care. We'll share some more of that data with you, and I'll get to that in a moment. But you had people who took care of these patients say things to them, like when they said they had back pain, and they said, yeah, but I think you've had that before, right? And someone asked how they were going to get home, and they were told in the emergency room, well, you'll have to take the bus, which is obviously the accident they just got in. And those are the things that were seared in these people's brains. And so I think we have to start by talking about definitions, right, to define things. So what do we mean by compassion? And there's a difference between empathy and compassion. It's a huge debate in sort of the nerd circles of this kind of stuff that we run in. But here are really the operational definitions. Empathy is that feeling or understanding of someone else's emotions. Compassion is your emotional response to someone else's pain that involves taking an action. So empathy is part of compassion. Empathy lights up the parts of the brain that are negative emotion, parts of the brain that actually hurt. Empathy hurts. Compassion, when you take action, actually lights up a different part of the brain. It lights up the part of the brain which is positive emotion. So empathy plus action equals compassion. Empathy hurts, but compassion heals. Now, done a number of these talks now, and it always comes down to this. This question comes up in the first couple of questions. So I've just started addressing it right out of the gate, which is people say, well, look, is this crisis that I'm going to try to prove to you we have in compassion, and before I show you the data, is it our society in general that's just bleeding over into medicine? So, and I'll tell you the answer, maybe. I'll give you some data points, but it's not as rigorous as the data we have on outcomes and other things. But a pair of surveys asked Americans more, and the reason why I have both sides of the aisle up here will make sense in a minute, to have the Republicans and Democrats. A pair of surveys, I'm not going to get political at all, I promise. A pair of surveys asked Americans a very concrete question. In 1960, they asked them whether they asked these parents, would they be displeased if their child married someone outside their political party? And then in 2010, the same question was asked again. Would you be upset if your child married someone of the other party? In 1960, about 5% of Americans expressed a negative reaction to this party intermarriage. In 2010, it was 40% had a problem with the idea, and it didn't matter which party you were talking about. So the unwillingness to look inward from one's sort of own bubble is ironically, one of the few things that it seems like all political parties kind of share, right? Because this is growing on both sides of the aisle. But by remaining in a bubble, it's like everyone's becoming sort of unable to see each other's humanity. And in order to show compassion, you have to see someone else's humanity. So a couple more data points. A meta-analysis from the University of Michigan synthesized data from more than 13,000 US undergraduate students. And they found that what they call dispositional empathy, so really their empathetic concern for others, declined sharply from 1979 to 2009. And that decline was sort of picking up. And before we go and blame parents, there's another study to know about. That's US middle and high school students from 33 different schools. In a different study were asked what they believe their parents value the most. They found that nearly 2/3 of our youth in this country and their parents do not value caring for others as much as they value achievements and accolades. So while parents deny saying this to their children, the study offers pretty solid evidence that that's what people picked up. So let me show some evidence that there's this gap and that we're not as compassionate as we think we are. So does the US healthcare system provide compassionate care? Well, whether you're a physician or you're a patient, around the same we say we do. But do US healthcare professionals provide compassionate care? And there's a really big gap there. And the research shows we routinely miss emotional clues from patients and probably miss somewhere from 69% of opportunities to respond to patients with compassion. In fact, it's nurses in the study who had a more realistic view of the doctor's emotional intelligence, right? An independent third-party analysis. And that's a lot of what this is looking at objective standards of compassion. When a patient says, I'm having a rough time, the hope is that there'll be what they call open questions and not terminator questions. All of this research is very rigorous. But more often than not, physicians kind of blow past those opportunities for compassion. So a little bit more of this, you might say, well, hey, maybe that depends on what specialty you're talking about. So what percent of the time is there a meaningful lack of compassion? Well, there's a range of studies, like I said, 60 to 90%. But what about, well, maybe that's because if you look at someone, for instance, who's a hospitalist, that they don't have, they have episodic care with people. So the hospitalist, maybe here's a couple studies that say hospitalists, maybe that's the issue. If you take the hospitalist out or you focus on someone that has maybe a longer term relationship or a deeper relationship with patients, you won't have studies that show that they're missing opportunities for compassion. How about intensive care, right? You would think the intensity of that. No, studies that show the same thing, that there's missing demonstration of compassion when interacting with patients. Okay, well, how about that? The hospitalists in the ICU, that's episodic in care. What about someone who sees patients all the time and really bonds with them? How about one of the biggest bonds around, oncology? So what about oncologists? Same thing, right? Still missing a chance to respond with compassion when that opportunity is there. about primary care, right? Still 70-90% missing emotional cues to respond with compassion. So fine, say, okay, all right, I buy all of that. But when people are having discussions about end of life, those must be periods where we don't miss out. However, one study showed that family meetings had 0 statements of compassion when there were family meetings about end of life. So this is me trying to make the case here that we have a crisis. Here's a moment I want you to take a look at this famous Victorian painting. It's called The Doctor. It was painted by a painter named Sir Luke Fields. And he was commissioned from Sir Henry Tate, who was a sugar tycoon. And he was founder of this famous Tate Gallery in London. And he commissioned the painting, and the painter himself had lost a child. And when his child was sick, he remembered the focus that the physician had on his child. And that was something that really meant a lot to him. The character of the doctor through time, the anxiety that made a deep impression on him, that of being so laser focused on his child. And that's what he painted in what is now a very famous painting. So contrast that with this. So this is a sort of, this was published in JAMA, the Journal of the American Medical Association. And it's by a physician who received this as a gift from his 7-year-old patient. And he was someone that considered himself very close with his patients, and but he was appalled when he got this picture. Because if you look carefully, there's the picture of the patient sitting on the exam table happy. There's her mom with her siblings, and everyone's happy. But look at what the physician's doing. This 7-year-old's vision and thought process when thinking about her pediatrician, who she liked so much she was giving this gift to, is with his head buried in the computer. The Johns Hopkins study found that resident physicians on inpatient services spend only 12% of their time seeing their patients at the bedside in direct patient care, compared to 40% of their time doing computer work and doing things away from patients. So this is, I think, where we've come when you look at where that's happened. And here's my sort of last tidbit to try to prove to you, make the case that there is a compassion crisis, and it's this: that the number of citations in people studying compassion has grown enormously over the last several years. You might say, wait a minute, what does that have? Why does that prove there's a crisis? Well, we don't usually see a rise in the study of things when it's not a problem. I can tell you there's not been a spike in studies of the bubonic plague in the last several years, but you can bet this is what it's going to look like for coronavirus. And so we really believe from the data that there is a compassion crisis. So the question is, does it matter? Does it really matter? Because it either matters or it doesn't. Yeah, we all agree you ought to provide compassionate care. We all agree that it's something you should do. We wouldn't have gone into medicine if we didn't feel that way. But is there something more that doesn't matter in meaningful and measurable ways? Well, we tend to think of the science of medicine separate from the art of medicine, and that a lot of these things I'm talking about would be in the art of medicine. But maybe there's actually science in part of the art of medicine. Does compassion matter in meaningful and measurable ways? And that's what we start out to find out. Let me tell you how this journey began. For me, is the first step was in around late 2013, early 2014, after I just become the chief medical officer for Cooper University Healthcare. My boss at the time came to me and she said, look, you have two things you have to focus on. You have to focus on patient satisfaction and physician engagement. Our scores are really, really bad in that, and we really want to get those better. But don't worry, I've hired a consultant for you. And this consultant is going to help you, tell you exactly what you need to do and have the faculty do, so that we'll have better patient satisfaction, better physician engagement. So I said, great. So I meet with the consultant for the first time, and I thought, oh boy, this is going to be rough, because all of the things that they told me seemed so mushy to me. I just thought to myself, how am I going to get, at the time, about 500 different faculty physicians, how am I going to get them on board with doing something that just seems so kind of soft? So the first thing I did was I turned to our #1 NIH researcher, both at Cooper and at CMSRU, He has a national reputation as an investigator. He's been published in JAMA, New England Journal. He's got publications everywhere. And he is a science guy. Here he is. This is the most emotional picture I could find of him. Here he is. He's rolling around in laughter in this picture. If you get to know him, he doesn't have much emotion, because he says things like, without data, you're just another person with an opinion. Or he's known for saying, in God we trust, but all others must bring data. This is the guy that I went to. And I said, hey, Steve Treziak, his name. I said, I really, really would like you to be our champion for patient satisfaction and physician engagement, and help me convince the faculty to do all these things. And he was like, I'm not your guy. I'm the science guy. I mean, another data point on Steve is he runs a chili competition in our hometown that is a blinded chili competition, so he can make sure that the way the winner's chosen has the purest right data in it. So I say to him, come on, I really want you to do this. And he said, why me? And I said, look, I just need you to science this up. Is there any data behind it? You don't have to do anything. At first, just tell me if there's any science behind it. So Steve went off and started looking at some of the data. And I said, let's meet in a couple of weeks. And what he found was miraculous. And we were enthralled with what he found and made the decision to move forward and look at it even further. In fact, we looked further and further and further, to the point that we looked at over 1,000 scientific abstracts, 280 research manuscripts. So everything I'm about to tell you today, it's not what we think or believe, it's what we found. It's actually in the data on the biomedical literature. And I got very lucky, because at the same time, Steve was having a bit of a moment. I mean, these are the things that he would research: sepsis, and that was his main thing, and resuscitation research. And those were the things that he would look at. And he had a little bit of a change of heart too, in some sense. He tells a story about his 12-year-old, and his 12-year-old son came to him. He was going over, what are you doing? What work are you doing? And his son said, well, I have this assignment due in a few days. It asked me to describe the most pressing problem of our time. So his son gave him the answer, and Steve said to him, do you really think that's the most pressing problem of our time? And his son said, no, but that's the one that I have the most, like, I'd already kind of looked up and I know a lot about. But the rest of the assignment was to convince the class that it was the most pressing problem of your time. And Steve said to his son, listen, Christian, you're never going to convince the class if you don't believe it yourself. And then, his son, who was probably not happy that his father was telling him to redo an assignment, went back and came up with a topic that he really was passionate about. And then he presented to his class and made Steve think about the work he was doing, and was his research on something that he really felt was akin to, from his lens, the most pressing problem of his time. And that's how we sort of decided, hey, listen, these signals we're seeing in the data is amazing. And we want to make sure we collect this and tell the story. And in telling the story is how we think we can get an evidence-based faculty to change their behavior. So, which is hard to do, right? I remember when I started medical school, I was told that 50% of what I was going to learn was wrong, but the school just didn't know which 50% that was right now. And changing minds in medicine is hard. So the idea that I'm going to make the case to you that compassion should become part of evidence-based medicine is a difficult one to sort of follow, because you have to really change your mindset. And changing our mindset in medicine is hard. But then we look back years later and it's, it almost seems silly what we thought originally. So I don't know if anyone knows what this is, but this instrument is a tobacco enema. So in the turn of the century, between the 1700s and 1800s, there was a huge divide in the critical care world. And that divide was between whether, and they would have debates about this, about whether when someone stops breathing, it's best to blow air in their mouth or to blow smoke up their behind. That's where the expression comes from. And of course, I don't want to spoil it for those of you who are in your early years, but when you get to later in physiology, it's the air through the mouth people that ended up winning this debate, right? And so the idea, though, is that it took years to change that mindset. And so the same is going to happen here. Even having the data isn't the same as actually changing people's minds. We have to change our practice. So once we gather this data, We call this branch of knowledge and scientific study the effects of compassionate care on health, healthcare, and healthcare providers, Compassionomics. Economics is the study of the economy. Genomics is the study of genes. So the study of compassion science is Compassionomics. When we say health, we mean outcomes. When we say healthcare, we mean the delivery of healthcare, for instance, costs. And then when we say healthcare providers, we mean what impact does it have for those that actually provide care? And that is all of the data that we curated, literally all of the data over about a 2 or 3 year period. And what we found is that compassionate care is evidence-based medicine. And let me give you the caveat. We don't have any magical thinking here. If, the surgeon's knife cuts the wrong thing, or someone gives the wrong medication, sometimes, no amount of compassion can overcome for those things. But it really is an incredible intervention. And that's what we're going to talk about, that its presence makes a huge difference, and so does its absence. So let's look at those areas. Let's look at outcomes. Let's look at costs. Let's look about what it does to individual providers. So first, let's say outcomes. So I'm a huge entertainment industry junkie. So I tend to bucket things and think about, I think back to how movies and TV. So when I think about outcomes and compassion, I always think about this movie. So I don't know how many of you know, I'm going to date myself with all these movie references, but this is Hoosiers. It's one of the best sports movies of all time. And this particular character, his name's Ollie, goes to the foul line when his team is behind by a point, and he shoots 2 free throws. He comes off the bench, and that's why he's in the game, because there's a reason he's in off the bench. And he makes them, but he shoots it underhanded. So I don't know if you know what I'm talking, like the underhanded style. And of course, everybody kind of sneers and snickers. But the point is, what does it matter if what he's doing different, if he gets the outcomes? If you believe in the science and you get the outcomes, what does it matter how you do it? So if compassionate care is evidence-based medicine, then there must be mechanisms of action in which, when 2 people are connected to each other. And it turns out there's about 22 of them. There's physiologic, psychologic, there's things that have to do with self-care. There's physiologic ones that are stress mediated with your immune system, your endocrine system. We're going to talk about some of these. But first, you have to believe that the connection between 2 people matters. And I think it's the most interesting one to sort of prove that is to look at the Harvard study of adult development. So in what is the longest running scientific study ever conducted, 80 years and still going, they looked at a bunch of teenagers from Harvard. So 268 Harvard sophomores, all men, as well as a group of Boston teenagers, all beginning in 1938, who were also men. Why were they all men? Because Harvard only had men back then. So they watched them over time, and they followed all the key trajectories in their lives. And every year or so, they would do psychological assessments, they would do medical assessments, they would do blood tests, and all to find out what the key factors were to be responsible for their good health and happiness later in life. And what they found was that the biggest predictor at age 50 of whether they would be alive and healthy and happy at 80, it wasn't their cholesterol, it wasn't whether or not, they had certain diseases. The number one predictor was how satisfied they were in their relationships in their 50s. It doesn't mean marriage, it doesn't mean a spouse, it means their overall connection to other people. That was the one identifier that was a bigger predictor of whether they would be alive and whether they would be happy, more than any other thing for their health. And so that sort of is one of the first big pieces of proof that connection matters. So here's some breaking news about this entire, sort of subject matter from the 1960s. In other words, these studies have been around. So these are studies this is from JAMA in 1960 and the New England Journal in 64. So 63 and 64. What did they find? That if an anesthesiologist went to the bedside of a patient prior to the patient going to surgery, that the patient needed less anxiolytic medication and afterwards needed less opioid medication. And they've since this time they've seen this multiple times over. And they've even seen that intervention doesn't need to be a physician. It could be a nurse. That intervening not only will lower the amount of opioids you need afterwards, lower the length of stay, but lessen the amount of anxiolytics you need going into the surgery. And this is something that they started seeing in the 1960s. So compassion is also associated with reducing diabetic complications. If you think about how many people have diabetes, think about every course you ever have when you start talking about patients, you're somehow talking about how it affects diabetics. So in one study that looked at almost 21,000 diabetics across 242 primary care physicians, they gave the physicians the Jefferson Scale of Empathy, which is the most validated empathy scale there is. The physicians took it and they looked at all of the patients who were in primary care doctors that were high compassion versus moderate compassion, low compassion. And what did they find? That if you had a high compassion physician, you were 41% lower odds that you would end up with an acute diabetic complication, meaning one that landed you in the hospital. The reason why we really want people to make sure that they have good glucose control. So, in these kinds of outcomes, you see not only happen in the physiologic outcomes based on those communications, but even nonverbal communications in studies have been found to be associated with having better outcomes. When they looked at physical therapy, and also when it comes to pain, in almost anything they've looked at, in fact, in everything they've looked at, just haven't looked at everything, studies where you can increase the amount of compassion will reduce the way people perceive pain. No one thinks it takes pain away, but it reduces the way patients perceive pain. And there's a bunch of different studies that show that. And also, physician compassion correlates with positive long-term outcomes. So in trauma patients, you might say, okay, this can't be true with surgeons, particularly with trauma. That's going to be different. But looking at patient-reported outcomes, which is one of the growing areas that people are looking at when it comes to the medical literature, with the biggest predictor that at 12 months after discharge, that patients would report that they're having good outcomes was if their empathy was high. High empathy from the physician was a bigger influence over almost anything else that happened to them. And look, if you look, lives with the partner is a big one too, because like in talking about that Harvard connection, loneliness kills. In fact, there's some studies that loneliness is on par with hypertension and smoking. So, and this has a whole range of effects. So in cancer patients, it's been shown in multiple studies to lower patients' distress and anxiety, sometimes the only endpoint we can think about in cancer patients. And it improves health outcomes in mental health with depression and multiple different forms of mental health issues. And we talked about acute diabetic emergencies and reducing them by 41%. Well, in physicians with high compassion, primary care doctors, they were associated with an 80% higher odds of optimal glucose and cholesterol controls. Think about how hard it is to get your patients to control those things. But if you have a doctor who's higher in compassion, it's more likely that patients will actually be compliant with everything they're doing and have higher levels. And even at the cellular level, this makes a difference. So patients with the common cold, where their physician has high compassion, they had more interleukins. They had a decrease in the duration of the cold, and they actually had decreased severity of symptoms. So there's a wide range of effects with respect to outcomes. And so it also can, in almost any disease you look at, here's one, when it comes to IBS. So even in IBS, compassion has been shown to be better than other interventions. Here's a study we did right here at our emergency department that a lot of people don't realize is that 25% of patients with life-threatening emergencies will meet the criteria for PTSD 30 days after they have that life-threatening emergency. So if you come into the emergency department and you have a really life-threatening emergency, maybe you get intubated or some kind of resuscitation, then a quarter of those patients will go on to develop PTSD. So we wondered, well, what if we did a compassion intervention? So we actually trained a medical student, and that medical student who helped us with this article, who is the first author on this paper, she actually did the intervention herself. And so she was trained and standardized, and she would go to the head of the bed. I think there was maybe one or two other medical students that did it, but she led this, and she would go to the head of the bed and have a standardized thing she would do to whisper to the patient and put her hand on the patient's shoulder during this resuscitation period. And what did we find? We saw a significant decrease at the 30-day mark in people who developed PTSD. So we talked about depression, things like hypertension. There's studies on that. One of my favorite studies is at Johns Hopkins. They looked at an HIV clinic, and they asked this question to the patients: does your doctor know you as a person? That's the question. Does your doctor know you as a person? And of the patients that said yes, They had a 41% higher odds that they were on what the best therapy was. They had a 33% higher odds of adherence and a 20% higher odds of having no detectable HIV virus in their blood. And so, of course, the lack of compassion, so that's all about the benefits of compassion, but the lack of compassion can also cause risk as well, because we're going to talk about burnout and medical errors that happen. And you can see here where you can actually have increasing, when you have emotional exhaustion and depersonalization, signs of burnout that the lack of compassion can lead to. You actually have surgeons who reported major errors, 2 to 3 times higher major errors. This is self-reported. Imagine what wasn't reported. So the lack of compassion can be tied to increased mortality in a couple different settings, including in the ICU. So it's not just its presence gives us benefit, its absence can also be harmful as well. All right, so we talked about outcomes. I think of Hoosiers. I think of this movie. This isn't really a sports picture, it's a movie picture. Whenever I think about costs, because the bottom line is, as we talk about Compassionomics, is the effect on healthcare, this delivery of healthcare, that no matter how great compassion is, if it's going to add costs to the healthcare system or be costly to give out compassion, it's going to have trouble adopting it into something that becomes a standard of care. So I always remember this movie. That's Rod Tidwell. If I ever had a football jersey, it would be a Rod Tidwell jersey. What was Rod Tidwell's famous expression in the movie Jerry Maguire? Show me the money, right? So show me the money. Can compassion really impact costs? Well, let's look at the data. So first of all, how big is the U.S.? Like, how much money are we talking about in the U.S. healthcare system? Like, how big of a nut can we go after? Well, if you look, the U.S. healthcare system, just the U.S. healthcare system would be the 5th largest economy in the world. Just the U.S. healthcare system, right? We may have the highest GDP. This would just be the healthcare system. You know, we're about $3.5 trillion in 2017. Our GDP is inching up to 18 or 19%. To put this into perspective, the entire movie industry is equal to just hip and knee replacements. So hip and knee replacements alone is more than Hollywood collects at the box office pre-COVID. And I'll show you this arrow, which I'll come back to later, because somewhere between the 18th and 19th largest economy in the world is the amount of waste estimated from the Institute of Medicine in the U.S. healthcare system. So how can it impact costs? Well, there's 2 ways it can impact finances, right? It could raise revenue, help you make more money, or it can actually decrease your expenses. So there is some evidence, although this is survey data, which isn't as good as randomized controlled trials and other kinds of data, that it could actually raise your revenue. Why? Well, because this is what people look for in doctors. Training experience only mattered at a small amount when they looked at patients, 27%, 58% of experience. What really mattered was the different elements of compassion. Do they take my concerns seriously? Are they easy to talk to? Do they listen? Do they treat me with dignity and respect? Way higher that mattered to patients. And in some studies, patients said they would pay more if they could get that they want kindness or compassion. They say that, you know, it lowers quality if it's lacking. And so these are things across multiple studies. This was done by Dignity Health, which is one of the largest healthcare systems in the country. So it's also related, interestingly, somewhat to clinical competence. So we sort of assume that doctors sometimes can either be compassionate or good at the hard science. Well, it turns out that's a false choice, right? So, and that's been studied multiple times, and that compassionate physicians are actually considered better clinicians. They've done these studies where if you are more compassionate, you are viewed as more competent, even if you're not. Some of these studies were done in medical students where they looked at the objective graders on OSCEs, and then they looked at other people grading the OSCE all through videotapes, and then the patients. And the people who were more compassionate actually were scored as being more competent, even by professors in the medical school. So admittedly, right, when we look at patient experience, it also drives your financial performance, right? So if you're a healthcare system, let's say a hospital, this is going to sound like it, of course, but places that have higher experience scores do better financially. And same go for physician practices. So those things kind of go together, even when you control for things like demographics and socioeconomics, all those things. If you have more experience scores, you do better with respect to finances. And health systems that promote compassion and practices that promote compassion perform higher on HCAP. So that's the standardized hospital-based scoring. And particularly when they reward compassion, they are more likely to be recommended from patients to other people. Here's another way that compassion affects things. We're going to talk about burnout and the impact of compassion on burnout. But if you grant me the assumption before I prove it to you that compassion can reduce burnout, physician attrition is enormously expensive, right? So it costs a lot of money to switch out a physician for another one, because it's not just the salary, right? It's the loss of productivity during onboarding. It's the amount of money. It's the non-productive time. It's the amount you lose in between. So there's an estimate that about $4.6 billion a year is the cost of physician burnout. And that may be underestimated. And that's just the physician side. What about nursing, right? So there's a lot. And here's another chunk of this healthcare system money that we can get back if you improve the compassionate care between patients and those that provide care, which is there's almost $300 billion in annual costs that are due to non-adherence in medications. And adherence to medications, from the data I showed you, is one of the biggest outcomes to providing more compassionate care. Then, of course, there's the cost of medical errors, right? If we commit those errors that we talked about, then errors have a huge cost overall. In fact, those costs are not just the cost of, okay, someone had a complication and now there's cost of the complication. But when people die, or you have other medical errors that put people out of work, you have to now say, okay, that person's out of the workforce for X amount of time, or if they die for the rest of their life. So that has been estimated in multiple studies to be somewhere between $735 billion and almost $1 trillion a year, which is increased mortality rates and lost work productivity. So errors are a problem too. Now, here's another one. Compassionate care reduces healthcare spending. So when multiple studies looking at patient-centered primary care, when you have very patient-centered primary care and you really connect with patients, you order fewer diagnostic tests, you reduce specialist referrals, you lower overall hospital admissions, and you decrease the overall medical charges for those patients. And then the failure to provide those things has been shown to have higher diagnostic tests in a different study, or higher healthcare spending. So the median charges in the one study I'm talking about here, 51% lower with those who provided what was deemed to be patient-centered care. And then, of course, there's malpractice, right? The thing that when you talk about wasted medicine, all of us doctors want to say, like, that's it. If we could just get rid of that. Well, the cost, including the cost of defensive medicine, is probably about $56 billion a year. Remember, I showed you that arrow that the Institute of Medicine says there's probably about $735 billion in waste, but fine. Even if you doubled or tripled that, it's still nowhere near all the waste in healthcare. But what can compassion impact malpractice cases? Well, it turns out when you look at the data, patients and families decide to litigate because they perceive that their doctors don't care. There's even some randomized controlled trials with this in using certain scenarios. So they look backwards at data and forwards. So it turns out when someone sues, it wasn't the technical part of the medical care where we often fell. It was the caring part of the medical care that often becomes the reason and the decision that patients make the decision to sue. Now, it's not just between the care providers and the patients. It's also the way we treat each other that can make a big difference. So in one study of a nursing home, long-term care facility, they really put a lot of time in over a couple of years to changing what they called their compassionate culture. And they called it a culture of companionate love, and the way they treated each other. And what did they find? Well, when they changed their culture and the way they interacted and had more compassion for each other, they tried to take each other's pain away, meaning they cared about each other. They gave people the opportunity to give away their sick days to other people and do all kinds of different things where they could show compassion to their colleagues and really try to change that culture. What did they show? Teamwork went up on different scales that they measure. Absenteeism went down. The provider experience went up, and the emotional exhaustion quotient went down. And of course, that bled over to the patients, who they reported a higher quality of life and less visits to the emergency department. Now, I went around to everybody, my co-author and I, Steve Treziak, and we said, look, we're testing a hypothesis here it gives us more credibility if we can say, look, this thing isn't really a wonder drug. There's some things where it's going to go in the opposite direction. So we asked everyone, can you think of a situation where compassion would raise costs in healthcare? And of course, it was my colleagues in the emergency department that said, I could think of one. That what often happens is that you have patients who come back to the emergency department over and over again. And if we're nice to them, and not that these people are cold-hearted, the nurses, but if we're nice to them, then they're going to take up a spot from someone who needs it. So we can't be nice to people who we think are here because it's cold or we don't know why they're coming back. So someone did this study. And I said, well, that makes sense, right? Like that probably makes sense. What does the data show? So in a study of 133 homeless patients, that each one averaged 7 times annually or more that they went to the ED. And by the way, the study is interesting. They couldn't be severely intoxicated. So they could be a little bit. And they didn't tell the ED they were doing the study. And they assigned someone to do what they called a compassion intervention of either nothing happened or the person went into the room and these trained volunteers would talk for 5 minutes to the patient. And they would talk about anything. They would talk about movies, TV, their childhood, where they're from. They would have these, they didn't offer them food. They didn't offer them anything of substance. They just were nice to them for 5 minutes. And what did it show? It showed 33% fewer ED visits in the people that got the intervention. I cannot explain it, but even in the instance where we wanted to have some credibility and say, well, look, of course, sometimes compassion can increase costs. There was data that we couldn't find it. So then the next thing you got to think about is time. And I think some of you are probably thinking about that, which is, yeah, but how much time does this take? By the way, this is my slide to remind me of time. I don't know how many of you know what movie this is. Again, I'm dating myself, although I bet most of you have seen this movie. I'll give you another hint. At the beginning of the movie, it's called Twin Pines Mall. And then at the end of the movie, it's called Lone Pine Mall. It's Back to the Future, right? Because he knocks down a pine tree. Some of you may have never noticed that. But time, right? I think about the bucket of time when I think about the data in compassion. And 56% of physicians say they lack the time to be compassionate to patients. This was a Harvard study. So the question is, how much time does it take? So in one study of cancer patients, they actually did this study where they did an intervention, where they had at the beginning of the visit and at the end of the visit, they had the physician read something and standardize what they said. And they wanted to see if it could reduce the anxiety in cancer patients. So I'm going to actually read it for you now, and let's see how long it takes. From the oncologists at the beginning of the consultation. I know this is a tough experience to go through, and I want you to know that I'm here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We are here together, and we will go through this together. And then from the oncologist at the end of the consultation, I know this is a tough time for you, and I want to emphasize again that we are in this together. I will be with you each step along the way. So how long did that take when they timed people in the study? It took 40 seconds. 40 seconds to have a compassionate intervention that had a very statistically relevant impact that decreased anxiety in cancer patients. And that's not the only study. There's actually 5 different studies that all were less than a minute, where a compassionate intervention, a thoughtful, concerted intervention of compassion actually proved to have better outcomes. And so I think that leads to have to talk about this for a minute, which is, for those of you who don't know this picture, this is the Good Samaritan. And so some of you may have remembered the Good Samaritan study that was mentioned in the Malcolm Gladwell book, The Tipping Point. And so they did a study at Princeton University where they looked at all the seminary students. So it was at the seminary school. And they took the students who were in the school and they told them, hey, you need to go across campus and give a talk into this video camera. You're going to give a talk. And they told some of them they were doing a talk on the Good Samaritan. And they told other ones they were doing a talk on why they went to seminary school. And the Good Samaritan parable, for those who know, is that someone stops and helps someone who is in distress. So they randomized them to, you're giving the talk about the Good Samaritan or you're giving the talk about why you went to seminary school. Then they then what they did was they also had other data about these people, their personal attributes, their what they call their degree of religiosity, and all these different things. And then they told them, they further randomized them and told some of them, hey, you're running a little late. Even though everyone knows this campus and knows exactly where they're going. They just said, I think you're running late. And then the other people, they didn't say anything. And then when they looked at, then they wanted to, when they walked over, they planted what they call a confederate in psychology terms. They planted someone on the walk over to act like they needed help on the ground, kind of moaning that they needed help. And what they wanted to see was which factors predicted whether or not people stopped. And of all the factors, there was only one factor that was predictive, and it was whether or not they were told they were in a hurry. 63% of those in the no hurry group stopped, but just 10% of those didn't. Now, remember, they weren't actually in a hurry. They knew exactly where they were going. Someone just made them think they were in a hurry, right? That's called time poverty. If you don't think you have time to do something, you won't do it, even if you actually do. It's the opposite of something called time affluence. So time affluency is the perception you have more time. So in a kind of a really cool study, they gave people, it had people in 4 different categories. And they told people, look, some of them, they said you have a certain amount of time to waste. Other people said spend time on yourself. They told another group you have a windfall of free time. And then they had other people spending time on others. And then they asked them the impact of that on their time influence, their feeling of how much time they had. And it turns out the people that gave away their time actually felt like they had more time. So one of the ways to feel like you have more time is actually to focus your time on other people, which is pretty amazing when you think about it. So look, the other thing is, before we start talking about burnout, is can we train physicians to be more compassionate? The answer is yes. Of course you can train to be more. It's not inherent. It's not you're either born compassionate or not. You may be born more compassionate than someone else, but this can be learned. If every one of us right now went outside to throw a javelin, some of us would throw it farther than others, but if all of us were told how to do it and trained on it, we'd all throw it farther than we did the first time. So yes, we can train and intervene to help people be better at this. By the way, something for you, if you all want to go into academics, is that teaching the importance of the doctor-patient relationship is actually correlated with being seen as more of a role model from trainees and students. All right, let's talk about burnout. I always think of this movie when I think about burnout. This is a movie called Office Space. This is where the boss is always from Inintech, is always asking for the TPS reports, these mundane things. And so you can see where the people in this office get burned out. So let's talk about burnout. Burnout is essentially the idea, well, first of all, it's an epidemic in medicine. I'm sure you've heard about this before. There's probably lots of lectures and talks you've had about burnout, but it is an epidemic. And that these numbers just keep climbing about having this emotional exhaustion from what you do, depersonalization, where you're kind of removed from realizing that there's people you're working with, and then not finding any reward in what you're doing. Now, I will tell you that this was an interesting one for us we really wanted to look at, because I do not mean to demean wellness. I think wellness activities are great. So what I'm about to say, I don't mean to offend any wellness people in the group, but you know, a lot of times, a lot of the main things we were hearing when we started down this journey was that the way to defeat burnout was what we call escapism. So it's long walks in the park and hot yoga, and those things are important. But it seemed odd to us that the best way to engage and re-engage and enjoy what you do in your job is to get as far away from your job as possible. But the answer has to be at the point at which you're doing this. And could that answer be compassion? Well, at first we thought, well, this hypothesis will fail. So the book will be about the first 2 parts, or the data we find will be the first 2 parts. Because when I was in medical school, I was always taught, don't get too close to patients. If you get too close to patients, you will get burned out. But of course, if that were true, and that's how my co-author was taught too, but if that was true, then the higher the compassion that someone has, it should be the higher the burnout. But it turns out there's an inverse relationship. It's actually the opposite. And over 90% of the studies that looked at this, and there's several of them, it's an inverse relationship. And the other ones don't show it the other way around, right? Shows no correlation, but 90% show it's the inverse. So it turns out that compassion can be potentially one of the antidotes to burnout. And it kind of makes sense that if you lean in and don't just hear someone's problems and light up those empathy, right? Light up the negative parts of the brain. If you lean in and take action in a concerted, thoughtful way, you can light up the positive reward centers in your brain. Literally make you forget about your own problems for a while. And this relationship holds true in several contexts, in medical students, in primary care. They found it in nurses. They found it in senior executives. So it's not just even the way we treat patients, it's also the way we treat each other. That compassion doesn't lead to burnout. It may, in fact, be an antidote. So how can we measure this? Things like happiness? Well, there's a part of your brain that actually lights up when you're happy. This is a gentleman who is a Buddhist monk named Matthew Ricard. And he is, in what many consider, the happiest man in the world, because his prefrontal cortex on MRI lights up more than anybody else. It's way bigger than anyone at baseline. And then when he's doing something in particular, it lights up even more. What is he doing, and what does he do all the time? And what do a lot of monks do, Buddhist monks do all the time? They meditate on compassion for others. And that is the pathway for this being what many have called the happiest man in the world. So there's really only 4 reasons that we wouldn't treat patients with compassion, right? The first would be you don't think it matters. I'd like to think I showed you some data today to say, hey, it really does matter, right? It matters in meaningful and measurable ways. We might say, look, I don't have time, but like I said, the studies show that you do have time. You might say, look, I don't care, but that's the burnout talking, right? And we can solve that by leaning in on patients. And then the last one is, I don't know how, right? But you do, and you can train on this, and it's not hard to do, and we know that you can train. So, does compassion really matter? And the answer is yes. Compassionate care is evidence-based medicine. So, Steve, my co-author, likes to talk about his N of 1, that he was really suffering from all the signs of burnout when we started doing this. And so it was timely, and fortuitous, like I talked about. So he really started to intentionally do this and really leaning in with his patients, spending that intentionally trying to be more compassionate in the way he thinks about patients. And leaning in, and he found that the fog of burnout did lift away from him. He had every single sign of this. And I can tell you, neither of us claim to be the most compassionate doctors. We're both works in progress. But when you start to intentionally think about doing this and put it on the same par as evidence-based medicine, you will start to see these effects. Be your own experimental one. All right, that's what I wanted to present to you. I look forward to your questions. I hope I hit the mark on the time. And I'm ready for whatever you have for me.
Absolutely. Thank you so much, Dr. Mazzarelli. I think that was very interesting. I think I speak for everyone. There's a lot to consider. There's a lot to think about. So we do have a lot of questions that are coming in the chat. I want to begin with a question that I have really quick to start off. So with, I think, everything kind of moving towards telehealth and, and virtual, I guess, care a little bit more with the everything going on, how do you think this is affecting compassion? And do you think like there are ways we can show compassion even if we're social distancing and we have masks on? And what are some ways we can do that?
Sure. So a couple responses to that. If telemedicine is the alternative to no medicine, I think that connection is going to matter, right? In person versus telemedicine, we don't know. I mean, there's not a lot of studies on that. We're actually starting a study here where we're going to start trying to send 2 different introductory videos to patients before they come in and see us and the only thing we change is a little bit of the wording. In fact, it's very similar to the wording that I said to all of you, and see if their anxiety levels at the visit when they show up are different. That if we can actually, impact them before they come. So if we can impact them with a not even a live video, I would think that there is the ability through telehealth in order to make a difference. Will it be the same? Is it more? Is it less? It's a good study to look at, right?
Sounds good, thank you. So I think there are other questions as well. I'm going to start from the beginning. So this question is, besides open-ended questions mentioned at the top of the talk, can you list 3 to 5 behaviors that would be considered compassionate care? So I think
Sure.
you did mention some, but I guess elaborate.
Yeah, so yeah, and I've mentioned some, but a lot of them, you know, there was a study, we actually did a study where we looked at, I think it was like 30 or 40 different compassion and empathy training courses for physicians. And what we found is like 70, in the big meta-analysis, like basically they all work, right? So any of the things that you're taught to do, sit down, the patients perceive you as spending more time, you sit down, introduce yourself, to, you know, tell the patients what you're going to do, how long it's going to take, thank the patient at the end, just routinely thank the patient at the end and have your known thing for how you thank a patient. Those things have all of those different things work. It's really about the idea of emotionally connecting with the patient, which you can do.
Okay, thank you. And I think the next question is very long, but I think basically what they're saying is in med school, we're kind of taught to not be quick, but we're timed, and we have, to finish the patient interaction with a certain time. So usually it's like 14 minutes or less. And do you think that this norm will like be changing in the future, or do you think that it affects, you know, compassion? And you did say only 40 seconds, but
no, I don't think it will. Right, because so a couple of things to answer this. So one, like we talked about, you can do it in less than a minute. But I think a fair question, I'll ask a question. Hey, yeah, you can do the compassion in 40 seconds, but are you opened up a can of worms in a visit that now the patient's going to want to talk to you for an extra half hour, right? So there's studies on that showed no significant difference by having those connections to patients and really kind of leaning into that. So that by saying those things, you know, some of these studies are like looking at how soon it takes for us before we interrupt the patient. And so there's studies from different decades that show we interrupt in 11 seconds, we interrupt in 16 seconds, and now we interrupt in 12 seconds. But the most interesting part is that if you don't interrupt patients, they actually get to what they want to say in like 30 seconds, right? So again, that has to do with the perception of how much time you have, right? In the time affluence and time poverty and experimenting with these things, it doesn't take that long in certain circumstances.
And then the next question is, if seeing a person's humanity is an important part of compassion, how can understanding one's own implicit biases and struggles with understanding racism, sexism, transphobia, etc., improve patient care for people from like marginalized groups as well? Yeah,
so we think that's really important. So we sort of transitioned to do more diversity, equity, and inclusion research along with what we call our 5-item compassion measure. We developed a compassion measure that we add on to the questions we ask patients that identifies, and we've validated it through 6,000 patients, and now we've actually linked up and with 91 other hospitals did the study, so we can tell what patients think. And one of the things we want to look at is, okay, how does, when you want to think about things from a diversity, equity, and inclusion standpoint, how does that change? Do patients of different backgrounds perceive compassion differently? Or do they, because one of the things that you can find is a lot of times these studies show that all races and across every demographic and socioeconomics tend to give similar scores at a similar institution. And we thought that can't be right. So we thought maybe there was a non-response bias, and we've actually published that we did find that. In other words, if you go into, or we're in Camden, if you go and look at the scores, for instance, the patient experience scores, you're like, wow, it's really not that different for people that come from Camden versus from elsewhere. But then when you go in and you open those up and you go and you actually, or you go to, you can see that the people that answer the questions are, there's a bias of who those people are. And even though their race may be different or maybe not, but their socioeconomics are more like the people who answer from the suburbs. And that really there's a non-response bias, and we have to actually go to different groups to make sure that we're treating them the same, or that we're not giving them a worse experience or treating them with less compassion.
Yes, very true. And then the next question, this is, they're asking if you can please repeat your approach to managing burnout.
Okay, so again, now it's interesting, to be fair, the whole talk is the why, right? It's not really the how. right? So and remember, the how, to me, any of these things that, and let's put burnout aside for 1 second, any of these approaches to patients, whether it's, if Dr. Holzberg's giving an approach that he has designed from a physician engagement or patient experience perspective, no matter how you approach, they're all going to work as long as you can standardize and do it all the time. That's the how. We already knew the how. Remember, how I said the book started. People came to me and they say, hey, the consultant says do all these things. And then we looked up the data behind doing all these things everyone talks about. The difference is putting it on an evidence-based par with everything else. That treating people with compassion or doing the things to connect with patients isn't dessert. It isn't something you only do if if your belly isn't full from your full entree and appetizer. It has to be on par with everything else. Now, burnout was something we didn't even think about from the beginning. But the idea with burnout is whether if you lean into patients, if you actually think about and try to connect with them. If you say, look, I'm going to do these certain things, just like I'm always going to order the right order set on patients. Here's my bundle of things in compassion. I'm always going to sit at the bedside. I'm always going to say thank you and practice and do it. I'm always going to introduce myself. I'm always going to do certain things and do it consistently. That's where you're going to realize you'll start to connect. And it's okay to ask those couple extra questions to connect. And that's where you'll actually see that that sort of is what we have seen in the data lifts that fog of burnout, to lean into patients, not lean back. And it doesn't take as much time as you think.
Okay, so the next question is, some reports state that compassionate care decreases incidence of malpractice lawsuits. Is this something your findings would agree with?
Yes. Yeah, absolutely. So it decreases the number of lawsuits. It decreases the decision to file the lawsuit. So here's two pretty amazing statistics, right? There's this thing called the Harvard study and the Dazon study. Turns out the overwhelming number of negligence cases, malpractice cases in the US have no acts of negligence. So I can imagine some of you are now going, oh yeah, of course, I know that. But the inverse is true as well. The overwhelming number of acts of negligence don't become malpractice cases. And both of those things can be true, right? The decision on whether to sue has nothing to do whether there's malpractice. It has to do with whether the patient feels like they were cared for. And that's been shown over and over and over again.
Okay, and then the next question was, where/when do you think physicians lost their empathy/compassion?
I'm not sure we lost it. Well, that's not really true, but I actually think I'm much more positive about this. I think there's much more in curriculums in medical schools nowadays than there was when I was in school. I think there was some when I was in school compared to before. I think it's getting better. It's putting it on par with evidence-based medicine and realizing that it's just as important. That's the gap that we have. To not have it be when you're busy or when something's happening, to have it be the thing that drops off. I mean, if you got really busy, you would never say like, I'm so busy, I'm not going to care whether the antibiotic covers gram negatives or gram positives, right? You're still like, but this has to be on par with all those things. And look, you might say, well, hold on a second. I'm not going to be in a good mood all the time. How am I actually going to be able to do this? Well, or someone else might ask the question, can you fake it? Right. So I don't know if that's one of the questions in there. But Kanzi, you can do me a favor and be like, oh yeah, there's like 3 questions on that. Right. So can you, and the answer is you can, right? So there's this idea of something called superficial acting and deep acting. So if you fake it, if you just make yourself do the same thing every time, like the EMR doesn't care if you really want to give the right antibiotic or you accidentally gave the right antibiotic, right? You still get the same outcome. If you fake it with a patient, if you say thank you, if you make sure you have more open-end questions, if you make them feel like you know them as a person, all these different things, even if you fake it, they will still receive some benefit. They will not receive as much benefit on all those outcomes as if you really mean it, but they will receive some benefit. You will receive almost none, meaning the burnout portion of this, right? But then there's this idea of deep acting. And it's the idea that you don't have to be having a great day in order to turn, if you turn to a patient and still thank them and are upbeat with them, even though you're having a bad day. What about that, right? And it turns out that if you do that from a position of caring, you get all the benefits and they get all the benefits. If you're still leaning in and caring. So you might say, well, it doesn't make any sense. Well, what about parenting? Parents do it all the time. They get home, they've had a terrible day, but they end up protecting their children from that bad day and they put on a happy face. Are they faking it? Maybe, maybe not, but that's deep acting. It's acting or doing something from a position of caring. And that's where you will light up those pathways in the brain of reward.
Someone just said that they were going to ask that next. So there you go.
Thank you. Whoever that was, I have to thank, because they did that. Thank you. Yeah.
That was Josh.
Thank you, Josh. Yeah.
So the next question is, has electronic medical records decreased patient connections and thus decreased compassionate healthcare?
Yeah, so this is a great one, which is people blame the EHR, EMR for a lot of problems, right? But I think what a lot of people don't realize is that the EMR came along during the same period where a huge increase in regulatory burden of charting came along. So in other words, if we didn't have the EMR, everyone's like, oh, I got to click all these boxes. Well, if you didn't have the EMR, you'd have to write all those things in the boxes, right? People kind of forget those things happen at the same time. And EMR has probably saved lives. I mean, the ability that we can actually read what people wrote, it's hard to make the case that that's a bad thing, right? Now, the question is, has it disconnected us from patients? Well, we need to find a way to have it do the opposite. I actually believe technology is the answer to this problem. I actually think none of us, I hope to still be seeing patients in 10 years. I think none of us are going to be writing charts in a decade. Now, within a decade, and I've already seen some of this technology. We're about to implement a pilot project here at Cooper, that there is technology that you just talk to the patient and there's a microphone listening in and you have to, consent to everyone. And then it uses artificial intelligence and voice recognition to just write the chart and make all the orders for you in your discussion with the patient. And it's in fairly early stages, but in a decade from now, none of us, because everyone sees patients for free in medicine. We get paid to do paperwork. And so I believe that the EMR, like a lot of people think of it as that's the problem. I think it's more a symptom of a bigger disease. I mean, part of it too is that we can't stop looking at it, right? I mean, if you were a family medicine physician 30 years ago, the amount of work you could do would be the number of charts you could carry under your arm. Now you can log in anytime and that inbox keeps filling and filling and filling. I mean, I don't know how many of you have an inbox of 0 for your email, but imagine your inbox in the EMR where people's lives depended on it. So you can see where we have to tame those tools to make sure they work for us. And the EMR was initially a way of getting information in. Now we need to do a better job of how we get information out and we manage information, but I think it's actually going to be the technology that helps us.
And then the next question is, I think, also this you kind of touched on, but what do you notice is different about the current generation of medical students compared to your generation?
Oh, well, I'm going to give a controversial answer to this. Nothing. I really don't. And people disagree with me all the time, like this whole thing about like millennials, and I think it's always the same. The older people think younger people have less respect or they don't work as hard. Like I walked uphill both ways. Like all the things that I hear our residents or medical students, all their needs and wants are the same things we had as medical students. I really don't think it changes that much. The world around us may change and the context we're in, but I know I'm alone in that. I don't have data for that. So that's a total, like just me going rogue on my opinion, but I don't really think it changes that much at all. I think the students that I interact with are very much the same as when I was a student. We have this sort of recall bias of the past, right? So like when I was a third year medical student and Dr. Holzberg was the chief resident OBGYN, like, oh, I was here all the time and he worked me to death and he asked me so many more questions. He was meaner than they're allowed to be today. This is exactly the same, right? So I think that's something in medicine that we struggle with. because we do know that in studies that medical students on, for instance, the Jefferson Scale of Empathy, their empathy is highest in their first and second year, and then it starts to decrease in third and fourth year and goes down in residency. So there's something about that hidden curriculum when we interact with physicians and residents that takes medical students and drives out some of the empathy they inherently had going in, and we need to focus on that. But I don't think that's changed in any generation. But I know that's controversial and people wouldn't agree with me, but I don't think it's really changed that much.
Okay, so the next question is, what are some ways on how we can start preparing medical students now and educate them on the impact of compassionate care before they enter residency and eventually full practice?
I think it's doing things like this, right? It's having talks that, knowing it's a focus, having it be part of your curriculum. You have, knowing your faculty is something they care about, and they do, or I wouldn't be here. And to continue have it become part of curriculum, but hopefully watch it rise up so that it becomes something you do on a regular basis. And don't forget, and remember, it's also the way we treat each other, right? The way that we treat each other is a big part of this too. It's not just patients. And so if you can be other focused, if you don't think about yourself, but you focus about others, that is where all the data shows. You think this 280 studies or something, it's the next 500 are unbelievable that we couldn't fit in the book about being other focused, that it's the evidence that really being kind to others is the best medicine for yourself. You get ahead in any metric you'd want to look at. So I think that's something I'm thinking about your work environment. So I was talking about how that, the culture of companionate love at that one particular institution. And you might say, well, wait a minute, how does how you treat each other ultimately stop people, for instance, from turnover or leaving organizations? Well, let me give you a story that happened here. So one night there was a patient that came in and he had a bleed in his head. And it was a sudden ruptured aneurysm, and he was much older. And it was a very sad case because it didn't look like he was going to live through the night. And his daughter was here in the ICU and said, I just wish my father would live long enough for me to be married. And her fiance was there as well. So the ICU nurses get together and they use IV tubing to be a ring. They go and they get flowers that another patient willingly gives up from another floor. They got a cake, like an old pound cake from the back of the, lounge refrigerator. They ended up finding a staff member who was an ordained minister, and they did the wedding right in the room.
Wow.
So you can imagine how engaged you're in your job if you're one of the nurses that was there that night. You're not going to think about working in another organization when that's the kind of thing that people do to be so focused on the patients and being part of that story.
Wow, that's amazing. And then the next couple of questions, they're kind of the same, so I'm going to combine them a little, but okay. They said that, yeah, you did mention this a little bit earlier, but don't you think that there's a problem that you have to convince the physicians to be compassionate?
Well, do I think it's a problem? Well, I mean, look, it's not that I haven't found a physician yet who says and there's only one person who's actually published to say compassion shouldn't even ethically matter. Everyone else agrees ethically, you should do this. It's very hard to find someone who says I shouldn't do this. What they tend to disagree with is, I don't think it's evidence-based. I don't want to. So most people's hearts are in the right place. It's whether you can align their heart and their mind to realize these interventions matter. So, we sort of write at the end of the book, hey, if you got this far in the book, you didn't really need to read the book, right? But it's something you could give to other people or share this. And we wanted to give people the data and arm them when they want to talk to others who start to kind of lose their way when it comes to this.
All right, I think that is it for the questions. If there's anyone else who wants to put in a last minute question, they can. Yeah, I think I did combine a couple questions, so I think we got them all, I'm pretty sure.
Okay.
All right, Kanza, thank you very much. That's not an easy job. Dr. Mazzarelli, I can't thank you enough. As you know, we can all feel your passion for this, and I think most of the students who have worked with me understand probably now where I get my passion from this. So thank you very much for a really great talk. You know, I can't stress it to students enough. How you speak to patients, how you treat patients, the experience they have is more important than sometimes the medical treatment you give them. So I appreciate your time tonight. Thank you, everybody who joined us. We had a great turnout. I appreciate the questions, and I'm sure that Dr. Mazzarelli would be easily accessible for any questions in the future, whether you go through me or directly to him. He's, you know, as I call, at our sister institution at CMSRU, so he's easily accessible. So thanks again, Maz. I appreciate your time.
Thank you, everybody. Thank you for having me.
Yeah, thank you so much, Dr. Mazzarelli. I know we have been planning this event for so long, and we really appreciate your time. And I'm really glad this is recorded. I will definitely be watching it again because I was reading comments. I think I missed part of it. So I will definitely be referring back to your talk. I really enjoyed it. And I know I speak for everyone here, and I think we all really enjoyed it and thought it was very interesting. I also want to thank Dean Matici and Brittany Quintana. Without their help, we really couldn't have done this event. It was a very large event, as you know, you can see. So thank you so much for all your help, Dean Matici and Brittany Quintana as well.
Thanks, Kanza.
All right, good night, everybody.
Good night.
Take care, everyone. Good night.